बस
डन।
अभी देखिएगा, रिफ्रेश करते हैं, आपको दिख जाएगा।
ओके ओके। Good evening, everyone. If I'm visible and audible, please give me a thumbs up, guys. Any messages? Just Dr. Drishti says good evening. Good evening. Right? Properly audible and visible. Shall I start? Thumbs up, guys. Thumbs up. At least I'll have some idea that people are around. Okay. So I can see people have joined inside. Let's start with the session without wasting any more time. Okay. I am Dr. Vinish. I'm the faculty in anesthesia. So I got a message from Dr. Drishti. Am I audible and visible properly, guys? Yes. Thumbs up, guys. Thumbs up. Any single message from you? All of you are there. Okay. Fine. So let me start with the session. Anyways, anesthesia. When we are discussing anesthesia, clinical masterclass has been a series that we've started where we're discussing the clinical parts or the clinical questions, which you must have already seen. So yes, I got a yes from Dr. Cute Girl also, and Dr. Yusuf. Okay, yes, thank you so much, guys, for your for the thumbs up that you guys have given to me. As I was saying, this is a clinical masterclass where we are discussing basically questions that are clinical in nature. So anyways, anesthesia is also a clinical branch, but the kind of questions that come here are, are the ones which come joined with other branches. We'll discuss them also. And one by one, let's start with the MCQs. If there are any questions or doubts that you have, you can ask me directly. In this session, there is no question about isoflurane. There's no question about halothane, about ketamine, propofol, because these questions are typically anesthesia questions. As I said, we are discussing a clinical masterclass where we are discussing sort of, clinical questions or what clinically things will happen. So it's not about individual agents that we have come. It's a very small session, not a very big session that I'm going to take. And hopefully, I want it to be an interactive session the way that you guys have messaged me right now. So let's start with the first question. Right? This question again is all based on previous year's questions, PYQs and PYTs, previous year's topics. And based on that, we'll take a discussion where these questions are, not only just part of anesthesia, but they can be part of other branches also. Right? The first one is one of the common questions which come in every exam is regarding a road traffic accident. And based on that, they'll ask you, if a patient comes to casualty, what is the next step to be done on various scenarios? This question is based on that. A patient of road traffic accident is brought to the casualty with Glasgow Coma Scale 6 and with a maxillofacial injury. On examination, the blood pressure is 180 by 110, right? 180 by 110 millimeter mercury. And the heart rate is 50 per minute. And it's regular. What should be the next immediate step in the management of this patient? The options are urgent CT head, intubation and ventilation, about NTG infusion and atropine. Yes, guys, anyone? What do you think is the correct answer here? Anyone? As I said, I'd like it to be an interactive session. So in that case, when you give me an answer, and then I'll discuss it out. Right? I got one answer, and that answer is D. Anyone else? So guys, first thing, when we get to a clinical question which comes like this, Dr. Kajal also says D. Dr. Samantha also says, Dr. Sutapa Samantha also says D. Now, guys, first of all, when you read this question, this is where the examiners kind of catch you, right? Right. The point is, it's road traffic accident. Just read it properly. Patient has come to the casualty. Forget about everything else. Can you see Glasgow Coma Scale 6? Even if you don't see any other thing, guys, remember the first step when you read about a road traffic accident and they speak about the Glasgow Coma Scale on which any question comes in the exam. Remember, Glasgow Coma Scale less than 8 or even equal to 8. It is the place where patient cannot maintain his airway. Because the patient cannot maintain his airway in a condition like this, the first step, because EVM, all that is gone down. He can't maintain his airway. There's going to be high chances of aspiration. This patient less than 8, you need to remember that he can't maintain the airway. This patient cannot maintain the airway. Correct. Now the answer has been said correctly by all of you, and that is intubation and ventilation. So even without seeing anything, the first point, see, that's what the point is. When clinical questions come, are, some small things we miss out, and what did you guys miss out was Glasgow Coma Scale 6, right? So Glasgow Coma Scale less than 8, it means patient can't maintain the airway, right? Which means airway obstruction can take place. Apart from that, there is high risk of aspiration, okay? The risk of aspiration in this patient is very high. So there are two indications why you need to maintain the airway of the patient. He can't maintain airway because the tongue is going to fall back at the posterior pharyngeal wall. That's the first reason. And the second reason is risk of aspiration. And both these are indications for an intubation, maintenance of a patent airway. And second is to protect the airway from aspiration. All right. So therefore, the first point is to maintain a patent airway, which means an open airway. And the second is to protect the airway from aspiration. And therefore, everything else comes secondary. About the blood pressure, about the heart rate, about the CT scan. Yes, all that is needed. But this patient in the casualty cannot maintain airway. Dr. AJ Motivation says understood. Okay, guys, that was the first question. As I said, they are not very long questions. I'll take 14, 15 questions, not more than that. And we are going to discuss all these clinical scenarios. None of the questions are going to involve isoflurane, sevoflurane, halothane, right? Or IV agents like propofol, muscle relaxants. I'm not discussing all that today. It's just the clinical questions, right? The next one. A 15-year-old boy presented to the emergency department with difficulty in breathing after being stung by a bee. On examination, lung wheezes are heard and the lips are swollen. The blood pressure is 80 by 55 millimeter mercury. Epinephrine is injected as a part of the management protocol. What is the correct route and concentration of adrenaline? Epinephrine is the same thing, right? Same thing given to this patient. Intramuscular 1:1000, intravenous 1:10,000, subcute 1:1 lakh, and epidural 1:2 lakh. What is it that you want to give to this patient? Yes. I got one answer. Other people, fast. Let's put the answers fast so that I'll discuss it out. I got one answer. Though two people have given me answers. And Dr. Sudhir Bhai says Manthan. यार ये बहुत important question है. Guys, this ADR is a very important question. Just like I told you previously, RTA is a part of most of the questions. Similarly, this is also part of question. Very nice, Dr. Manik Rana. Very nice. Dr. Manik Rana has given the correct answer. And then his answer is A. Right? So about adrenaline, guys, remember this patient, first of all, we are talking about coming to the emergency department. Right? Same the casualty. The patient has a difficulty in breathing after being stung by a bee. That means a bee sting is there. Right? The lung wheezes are heard. The lips are swollen. It's sort of an anaphylaxis, right? It's a sort of anaphylaxis. The BP is going down. Epinephrine has been injected. When you're using it for anaphylaxis, okay, the answer is not 1:10,000. So you need to be clear how is adrenaline given. And this question was asked last year, not the same question. A similar question was asked in last year INI-CET, the November exam, where they had mentioned a similar question about a pediatric patient being given drug in the emergency department, which was given 1:10,000, which was the wrong option. So my point is to discuss how is adrenaline given. So when you give adrenaline to a patient, guys, remember adrenaline normally 1 ampule of 1 ml, right? This is considered as 1:1000, right? The 1 ampule that you get in your wards in the casualty that you see is 1 ml is 1:1000. When a patient develops anaphylaxis, where it is indicated, right? Anaphylaxis. In case of anaphylaxis, normally the preferred route is intramuscular. And here you're going to use this 1 ampule. This is 1:1000. When we talk about CPR, when adrenaline is supposed to be given CPR, this is the place where you can give it intravenous or intraosseous. Remember, even intraosseous route works for CPR, right? Here what you do is, you normally take, so this is single ampule that you have given to a patient directly. It is IM. When you speak of IV, it is 1:10,000 concentration that is given, which means 1 ampule of this adrenaline is diluted to 10 ml, right? The 1 ml ampule is diluted to 10 ml. So you're injecting that 10 ml of 1 ml drug, you've diluted it to 10 ml, and that is what you're giving it to the patient, right? So this is your 1:10,000. This is given IV. Also remember, in case of CPR, another route is indicated, that is endotracheal route. In case of an emergency, you are unable to get IV or intraosseous access, you can give it from the endotracheal route also, right? Sir, why CPR cases not preferred? I am not preferred. Why in CPR cases I am not preferred? IV and IO to choose why? Dr. AJ says 1 ampule plus dilution. That's what, 10 ml dilution. That is 1 ml, 1 ampule plus diluted up to 10 ml, which means 9 ml. You take 9 ml of normal saline, totally it will become 10 ml. Right? This is what is given, 10 ml push. This is what is given. Okay? That is the preferred route of the way that it works, right? That is what we are normally giving, because it's a very high when you have to giving through the anaphylaxis. Anaphylaxis with the preferred route to be given is IM. For CPR, it is IV or IO, right? Another, remember, when you're using it as local anesthetic, as a local anesthetic for any kind of surgery, here you're supposed to use it from the different routes, right? It is the infiltration that you're giving, or it's a block that you're giving. So when you're using it as local anesthesia, it is further diluted. So that dilution can be 1:80,000 to 1:1 lakh, which means you're diluting it further, and then 1:2 lakh. Now here, when you're using it as a local anesthetic, remember the most common used, in some books it has been mentioned as 1:1 lakh, but commonly what we see, the ampule which is available of, the vial, which is available of lignocaine ADR, that is 1:2 lakh. So here what happens in local anesthesia, you normally get a vial of lignocaine which is combined with adrenaline already. This is available, right? Vial of lignocaine adrenaline, and that is normally 1:2 lakh. That contains adrenaline 1:2 lakh. This is what is used for local anesthesia for blocks and infiltration. As I said, again a question comes here, which is the most common concentration used for local anesthesia. And as I said, some books have mentioned 1:1 lakh, but what you get in the wards, the most common vial, that is 1:2 lakh. Another question important over here is that apart from adrenaline being used in anaphylaxis, CPR, local anesthesia, there's one more use, and that is ADR many a times can be used for bronchial asthma through the inhalational route, right? So this is another use of a different route when you're using adrenaline, right? And that is used for bronchial asthma from the inhalational route. So this is about adrenaline. Another point is, when we're speaking about lignocaine, I need to mention this as well, that another question comes regarding lignocaine, various concentrations that are available. So remember, lignocaine is available in 0.5%, 1%, 2%. This 2% is the most common. The 0.5% and 1% lignocaine is normally used in dental procedures, and you normally have not seen in India so often, 0.5 and 1% in the hospitals when you've been working. 2% is the most common that you see. And remember, this 0.5 and 1% I've said, these are injectable. So whenever you speak of local anesthesia drug, there's a classification, right? The classification of local anesthesia drugs is going to be based on the route of administration and the drug properties. So you classify the first thing as either the drug is injectable or the drug is a surface local anesthesia drug. A surface local anesthesia drug gets divided into two types, which is soluble and insoluble, right? And injectable then gets divided based on the various properties that it has, that we'll see later. The soluble ones are drugs like cocaine or even lignocaine. So that lignocaine 2% jelly, that comes as a surface local anesthesia drug. It can come as a jelly, it can come as a gel or a cream as well. So this is your surface local anesthesia lignocaine. There's another drug over here called proparacaine. Remember, this question was asked recently, proparacaine. And where is proparacaine used? Proparacaine is used in cataract surgery. Okay, proparacaine is used in cataract surgery. On the other hand, insoluble, you get drugs like butyl amino benzoate, benzocaine. All of us must have used, oral ulcer gel, that Orasor cream or or yeah, Orasor cream, or the different names that they come in. So all those contain benzocaine, the oral ulcer gel. So these are insoluble surface local anesthesia drugs. You have drugs like oxythazine or oxytocane. That oxythazine is what is there in a common prescription that we give to patients, that is mucain gel, that works as antacid. So that is your oxythazine or oxytocane. So this is local anesthesia drugs which are insoluble. The injectable drugs are classified into two types. One which are less potent and short duration of action, intermediate duration and intermediate duration of action, intermediate potency, right, and intermediate duration of action, and long acting. Here I'm not going to go into too much details because I wanted to discuss the surface wala part over here. Any other question that you have, you can ask me. The last one is highly potent and longer duration of action. So this here you have drugs like chloroprocaine, which is the shortest acting. Here you've got drugs like lignocaine and prilocaine. And here you have the longest acting dibucaine, you have bupivacaine and ropivacaine. That's it. What's the use of oxythazine? So this is used in that mucain gel, guys. Mucain gel. All of you must have seen a local anesthetic gel. Antacid gel basically. Antacid gel. When someone says, no, gas, ho raha hai, gas. When you're sitting in the casualty and you in a government hospital and you get all those people, of course, people have those complaints. Gas ho raha hai, jalan ho rahi hai, chhati ke piche dard ho raha hai. You get all those people, right? So that what we prescribe, there is mucain gel. That mucain gel is what contains oxythazine. Okay, clear? That's mucain gel. That's the antacid gel. Now I'm coming back to what I was discussing with you. Concentrations of lignocaine. So 0.5%, 1%, 2%. Remember 2% why I wanted to discuss was the jelly. So the jelly part has come over here, which is the 2% jelly part. Apart from that, the lignocaine comes in a vial. It comes in a vial with adrenaline. That is the one, and the one which comes for IV use. So these are the ones which contain preservative. IV use as no preservative. Okay. Again, this is an exam question. This contains preservative. This has no preservative. Apart from that, the other concentrations available are 2.5%, which comes in amla cream, 4% which comes as viscous and nebulization, 5% that comes as a cream in the past for spinal, and 10% spray. These are the various concentrations of lignocaine. Okay, guys. So this was about the answer where I discussed lignocaine with you and I discussed adrenaline with you. And the question came as a clinical question. And this question is always asked in the exam, which route is preferred from where and how is adrenaline given. So we discussed the concentrations and the route of administration. We finished that. And before that, one more point is over here. The previous question, always remember this point, that whenever you get a patient of emergency, whenever you get a patient of road traffic accident, or you get a patient of any injury coming to the casualty, the first thing that you see is always Glasgow coma scale. And if the Glasgow coma scale is less than 8 or equal to 8, always remember you need to intubate the patient wherever possible. This is the most important thing. In case of a emergency airway management, always you will intubate the patient, right? Whenever you have an emergency, irrespective of injury, whenever there's an emergency airway management, normally I am going to anyways intubate the patient, right? Or I can do a surgical cricothyroidotomy. This is what is done. Okay, cricothyroidotomy. Cricothyroidotomy is what you must have seen in the Netflix Good Doctor series, right? Or you have seen in that South Indian movie Marcel, where Vijay is running at the airport and he takes his lungi up and he cuts someone's throat and blowing with a straw. That is called cricothyroidotomy, right? So that is done in an emergency. If you have time, elective surgery for elective airway management. If you have time for elective airway management, so in a cervical spine injury, you can do a nasal tube, or in a case of maxillofacial injury, you will put a tracheostomy, right? So this is what is done in case of an injury of the patient. Clear? So for elective, if it's a cervical spine injury, you might use a nasal endotracheal tube, and if it's a maxillofacial or injury to the face, in this case, I will go for a tracheostomy. Okay, clear? But this is for elective airway management, not in case of an emergency. Okay, next question. Yes, a newborn child has respiratory distress. Dr. Sutapa says What's cricothyroidotomy? Arey, cricothyroidotomy is when you cut the cricothyroid membrane. Cricothyroidotomy. Wait, give me a second. What is cricothyroid? If this is the trachea, right? Here is the thyroid cartilage, right? Here is the cricoid cartilage. And after that comes the rings of the trachea, right? The rings of the trachea. The first ring, the second ring, the third ring, and the fourth ring. So when you talk about a tracheostomy of the patient, normally what you do, the tracheostomy can be of two, three types, right? The upper tracheostomy and middle and the lower tracheostomy. So when you do a tracheostomy, you are going to cut these rings of the trachea, and cutting the rings of the trachea would take you almost 5 to 10 minutes. This is called tracheostomy. But in case of an emergency, you do not have so much time to cut the rings of the trachea and then put a tube from here, which is a tracheostomy tube. So normally this is what is done in tracheostomy. You put a tube from the tracheostomy, this hole that you prepared, this channel that you prepared from here. In case of emergency, you can't be cutting the rings of the trachea. So what you do in emergency is that this is the thyroid cartilage. Below that is the cricoid cartilage. In between them, this is the cricothyroid membrane. So what you're going to do is, in the cricothyroid membrane, I'm going to give a small stab incision, or you cut it as it is shown in those movies and all. They cut it with a, they've given a cut with the card, that debit card or credit card. They've given a cut with a credit card over here. So this membrane is seen easily in boys. In boys, now it's just below the Adam's apple. Just below the Adam's apple. In girls, it is slightly difficult to palpate, right? But otherwise, in boys, it is right below the Adam's apple. This depression that you see below the Adam's apple, this is what is called as cricothyroid membrane. So what you do is you give a small stab incision over here, and once you make a small channel, you can put a small endotracheal tube from here. Okay, so what you can do is, in this case, put a small endotracheal tube, which means if this is an adult patient, so in an adult patient, we are normally going to use a size 8, 8.5 for a male patient, right? Endotracheal tube. But if you're putting a small endotracheal tube, by that we mean you can use a 6 number, or 6 or 5, anything which has a cuff. So that becomes a definite airway also. So 5, 5.5 or 6, a small endotracheal tube, which is of size 6 or size 5, that can be inserted, because 8 would be going to be inserted from the normal mouth. But here, cricothyroid membrane, I can do that, or use a small tracheostomy tube. So this is what is called as cricothyroidotomy. Thumbs up. Okay. Next question. I thought it was very short time. I thought I'll leave you within 45 minutes. Okay. It's a third question, but anyways, we are going to take only 12 questions. Not many questions are there. Like I said, it's a clinical masterclass. We are just discussing clinical questions. A newborn child has respiratory distress. Again, it's a common question that comes in the exam every second year. On examination, it is found that the newborn has cyanosis and scaphoid abdomen. Which of the following is not supposed to be done in the management of this newborn, right? Nasogastric tube, bag mask ventilation, X-ray chest and abdomen, and intubation. Yes, guys. Jaldi. Jaldi means fast. Anyone? By now, I should have got the answers very fast, huh? What is the answer to this question? Okay, so what has been given in, it has been said that's a newborn child, just born, right? The child has respiratory distress. When you're examining, very nice. I think Dr. Mani Karana gives the answer, absolutely correct. The answer is bag mask ventilation. It is found that the newborn has cyanosis and scaphoid abdomen. So when this question comes in the exam, here, Dr. Ashlesh Krishna says, sir, Coke is bad. I know, yeah, Coke is bad. Thank you. Sorry, that is one bad habit which I have. Okay. Apart from that, no smoking, no drinking, right? This is one bad habit. But then that's why I preferred the diet 1 year. What an observation. Okay. Thank you for saying that. Nice, huh? All of you. Perfect. But whenever I take a class also, there's something or the other which always happens during the class, right? Nice, nice. Good observation. Good observation. All right. So Dr. Sutapa also gives that answer, and the answer is bag mask ventilation. So as I was saying, when we are discussing this question, a newborn child has respiratory distress. The baby has cyanosis and scaphoid abdomen. Normally, in a question like this, they will also say, what is this scenario? But sometimes this has to be judged by you itself. What are they trying to refer? So this is basically speaking about congenital diaphragmatic hernia. And this question always comes in an exam. Remember, congenital diaphragmatic hernia is a contraindication to bag mask ventilation when you do, or ambu bag ventilation that we do. Remember, I am now discussing those points which are the conditions that are called as bag, which are contraindication for bag mask ventilation. So what are bag mask ventilation contraindications? So all the conditions that are called as risk of aspiration, where a patient is likely to aspirate, is what are called as contraindications to bag mask ventilation. Especially in pediatric patients, it is congenital diaphragmatic hernia, tracheoesophageal fistula, pyloric stenosis, and meconium aspiration syndrome. When it comes to adults, remember the high risk of aspiration normally, I mean, even for child, this is going to be true for child as well. A full stomach patient is always a risk of aspiration. Apart from that, pregnancy is always considered risk of aspiration. In fact, even ascites, tumors, obesity are all considered risk of aspiration always. Intestinal obstruction, volvulus, hiatus hernia, or anything that causes, delayed gastric emptying, anything with a delayed gastric emptying is risk of aspiration. So this question again becomes important, especially from anesthesia point of view. I'll not go into too much details from there. But in all these conditions, ideally bag mask ventilation is contraindicated. You will not do bag mask. And if these people come for surgery, for example, you get a full stomach patient coming for emergency surgery in anesthesia, and you need to intubate for giving general anesthesia, right? I have to intubate for giving general anesthesia, and the patient is full stomach. I mean, or the patient is pregnant, and I have to give a intubation for GA. I have to do that. I somehow have to intubate. In this patient, there's always a debate, but still the books have mentioned that you are supposed to give something called as cricoid pressure. Okay, you are doing Sellick's maneuver right now. Nowadays, Sellick's maneuver is very debatable question in anesthesia, but at your level, just think that yes, Sellick's maneuver is done. We are going to give cricoid pressure. Guys, what is cricoid pressure? Same. Do you see that? I had drawn cricoid over here. So cricoid is the only complete ring that you see in the trachea. So if you put the pressure on the cricoid, this is called cricoid pressure. So if you put the pressure on the cricoid cartilage, it compresses against the esophagus and shuts off the esophagus. And that is what prevents aspiration. So this is an important question. Cricoid pressure is given 30 Newton, and this shuts off the esophagus. Because it shuts off the esophagus, it helps to prevent aspiration. And then you give the induction agent, muscle laxate. As I said, I'm not going to discuss that. I just discussed what is done in a patient of risk of aspiration. Clear? So this is your bag mask ventilation and risk of aspiration in anesthesia. Clear? Next question. Any doubts you can ask me? Again, a proper clinical question which has been asked many times in exams. Similar question, similar thing, and this is an important one, right? So a 60-year-old male patient was undergoing laparoscopic cholecystectomy. During the surgery, it was observed that there was a sudden decrease in EtCO2 to 8 mm mercury. SpO2 was 90%. The BP dropped to 80/50, and the peak pressure, airway pressure, was observed to be 18. Which of the following is the most probable diagnosis? Dr. Sutapa says, sir, how bag mask ventilation give what? Question क्या है? Dr. Sutapa. What's the question? You write the question. I'll discuss it once I'm done with this answer, okay? और मेरे को शर्म आ रही है तो बीच में डॉक्टर अश्लेष कृष्णा सेड, तो फिर मैं बीच में सोचा से छुप के पीऊं, तुमसे छुपा के पीऊं. Okay, yes, anyone? Answer to this question, and Dr. Sutapa, you can type your question. Right. So let me see how we approach this question. From what has been given, there's a 60-year-old male patient. The patient is undergoing laparoscopic cholecystectomy. How it is done? अरे बैग मास्क वेंटिलेशन, रुक जाओ, बिफोर आई कम टू दिस क्वेश्चन. ये तो बेसिक पॉइंट था. बैग मास्क वेंटिलेशन मतलब नॉर्मल. सी, बैग मास्क वेंटिलेशन क्या होता है इन अ ओटी? व्हेन यू स्पीक ऑफ बैग मास्क वेंटिलेशन, इफ यू आर स्पीकिंग ऑफ द ओटी, or you must have seen in the OT when we are getting a surgery done, we hold a mask on the patient's face, and along with that you will find an anesthesia bag attached to the breathing circuit. All of you know there's a Mapleson circuit. Let's take the example of Mapleson A. Mapleson A circuit is like this. You must have seen fresh gas flow coming from anesthesia machine. After that, you get a bag over here. After the bag, you get a tube. After the tube, you get a APL valve, right? Adjustable pressure limiting valve. And after that, here you get a mask. So this is the anesthesia machine connected circuit. This is what is called Mapleson A, which is asked in exam, right? Not a diagram is not asked, but you have to know Mapleson A, which is called McGill circuit or Lack circuit. So this consists of fresh gas flow. Fresh gas flow means oxygen and nitrous and all the inhalationals coming. Here you find the bag, right? And here is the tube. Here is the APL valve, adjustable pressure limiting valve. This is the valve. And here is the mask. So whenever you must have seen an anesthesia person in the OT hold the mask, normally it may be Mapleson A or Mapleson D. Remember, Mapleson D is more common, but I'm just trying to make you understand. Hence, I have taken the example of Mapleson A. Normally, Mapleson D is more common. So what we do is we hold the mask on the patient's face, right? And we press the bag from here to give the breath to the patient. So this bag is what is used to provide the positive pressure ventilation or breath to the patient. So this what is called now bag mask ventilation. The same thing is true in case of an emergency when you use an ambu bag to give breath to a patient. In emergency, when you're using an ambu bag, all of you must have done that in emergency in casualty. So through an ambu, when you give breath to a patient, that is also called a same thing, bag mask ventilation. Because in front of the ambu, you'd always see there's a mask attached, right? So therefore, the same thing is seen in emergency as a ambu bag ventilation. Hopefully that's clear, Dr. Sudhapa. ठीक है, वो clear हो गया? अब ये point का answer, I think Dr. Sudhapa has given the answer. Anyone else? Right? I went back because that was a basic question that she had asked. So I said I'll finish off that and then come to this point over here. Okay. So as I was saying, in this एक आंसर आ गया डॉक्टर सुतप्पा का, तो वो करेक्ट मानते हैं. करेक्ट, दैट इज CO2 embolism. That's the answer over here. And 60-year-old male patient undergoing laparoscopic cholecystectomy. Remember, whenever laparoscopy is going on, you need to understand that you are insufflating the stomach with carbon dioxide gas. Right, you're putting the carbon dioxide gas inside the stomach, and right, everything is going to be visualized on the television. That's what we are going to do. You are insufflating the stomach, right, and then inside you're going to put that Verey's needle. Remember that Verey's needle is an important question, and that Verey's needle is used over here, and then you're going to see it on the television or the monitor. Basically, everything is visualized on the monitor. Visualized on the monitor. And that is why we are inserting the gas, that is carbon dioxide gas. That's the use of carbon dioxide gas. Now, when you have done that, suddenly it's observed there's a decrease in EtCO2 to 8. There's a sudden decrease in EtCO2. SpO2 has also fallen down. The BP has also dropped, right? All the three parameters have fallen down. And the peak airway pressure is 18. So guys, remember, 18 peak airway pressure normally is considered normal. Right? To go about other things, if I have to approach this question just from monitor point of view, if I will say the EtCO2 has fallen down. So if you take about EtCO2, a normal end-tidal carbon dioxide for IPPV looks like this. If I have intubated a patient and I'm giving positive pressure ventilation, so this is what tells me correct intubation and correct ventilation, right? In a spontaneous breathing, it becomes like this, EtCO2 graph. This is a normal graph. But what has happened now is that the graph has suddenly dropped to 0, which means there is no carbon dioxide now. So normally, what are the points of a graph falling down to 0? So normally it means no carbon dioxide production, means no carbon dioxide present in the patient, which means the first and foremost can be a cardiac arrest. There can be a cardiac arrest in the patient. Second thing is it can be disconnected from the circuit. The monitor is disconnected, or there can be accidental extubation. By chance, the endotracheal tube has come out. It was intubated, but suddenly, accidentally, the tube has come out. Right? It can be complete obstruction of the tube. In fact, it is also seen in esophageal intubation. But another important point is embolism. And embolism leads to a sudden drop in carbon dioxide. Okay? This leads to a sudden drop in EtCO2. Right? So there is sudden drop. Same thing is seen with cardiac arrest as well, right? Or even accidental extubation or disconnect in the circuit. All that is seen. And even no carbon dioxide means esophageal intubation. That is there. So embolism should lead to sudden drop, and that gives us the answer, even from that one thing. But in that case, what are the other options? In pneumothorax, endobronchial intubation, and bronchospasm. So normally this is not asked in exam, but a pneumothorax capnography normally would look something like this. Okay, pneumothorax, normally this is not asked in the exam. Emphysema and pneumothorax normally look like this. A pneumothorax and emphysema are normally like this. This is normally not asked in the exam, and we don't even teach students. Endobronchial, again, normally we don't teach students. In this looks like this. Endobronchial intubation, it looks like this on the capnography. Okay, this is endobronchial. And the last one is bronchospasm. This is asked in the exam. So bronchospasm is basically your shark fin appearance. Again, you people know this, shark fin appearance. This is bronchospasm. Okay, this one is what is called as bronchospasm. So therefore, from all this also, from that one point itself, you get the answer. But apart from that, in case of pneumothorax, right, in case of endobronchial, your tube has gone into the right bronchus, right? Here there is a spasm in the airway and pneumothorax. In all these cases, ideally, this airway pressure, guys, is not going to be normal. Another point. In all these cases, the airway pressure is going to increase, and here the airway pressure is given normal. Apart from that, a fall in saturation, BP dropping, all this can be seen in anything. It can be seen in pneumothorax. Both of them can be seen in bronchial intubation, and both of them can be seen in bronchospasm. So therefore, the fall in SpO2 and the fall in BP is not diagnostic of this answer. I mean, this is not what is giving you the answer. You have got the answer from this procedure, laparoscopic cholecystectomy, the sudden decrease in EtCO2 and the peak pressure being normal. These are the points that have given you the answer, that CO2 embolism. Thumbs up, guys. Is that okay? So we discussed that clinical part also. Hopefully all this is clear to you. Next question. During ECG, during CPR shows the following rhythm pattern. Next appropriate step is, so is it adrenaline, synchronized cardioversion, defibrillate, or amiodarone? Right, all clinical now. Agreed, all of you? Clinical masterclass. No halothane, no isoflurane, no ketamine, no propofol, no thiopentone. Only clinical questions. Clinical masterclass. All these have been asked in exam. Yes, guys. Answer, anyone? So many of you are there. Koi answer nahi. Right? What is seen? ECG, you have seen a pattern. What pattern is seen? Can you identify P? Can you identify QRS complex? Can you identify T? Can you identify anything? You can't identify anything. It is like, you know, moving tuck, 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 tuck. It's moving like this, like this, like this, like this, like this. Correct, Dr. Mani Karana, again, correct answer. Absolutely correct. Defibrillate. When you feel like this, like this, like this, what is happening to the heart? Dr. Sudappa also correct. Okay. So, ऐसे heart हिल रहा है. जो heart हिल रहा है, क्या हो रहा है? Fibrillate कर रहा है. Therefore, that is what you have seen over here. This is ventricular fibrillation. So when you get ventricular fibrillation, you need to defibrillate the patient, right? So remember, whenever you're continuing the CPR and you get a AED, you know, even if you get an automated external defibrillator, so you were continuing the cycles of CPR. So basically what was happening? We were continuing the cycles of CPR. How many are the cycles? Cycles of CPR is normally 30:2, which is continued for 2 minutes, right? So cycles of CPR is being continued. And during that, you get a defibrillator. So once you get a defibrillator, you attach the pads and you assess the rhythm. Once you assess the rhythm can be either shockable or non-shockable. So remember, the shockable rhythms are pulseless ventricular tachycardia and ventricular fibrillation. Here you need to give a shock, right? And when the rhythm is pulseless electrical activity and asystole, remember, these are non-shockable rhythms. Anyways, once you have given a shock, or if you're not supposed to give a shock, the next thing to do after that is no pulse check and basically continue CPR, right? Immediately after this, right? Immediately after this, when you have finished, nothing is to be done. You just need to continue the CPR. Continue CPR cycles, 30:2. And after that, what is to be done? Again, you need to assess the rhythm. Right? Again, this is the rhythm. So this is what is to be done. This is what goes on continuously. All right. So this is the point. Ventricular tachycardia is what is going to look like this. Something like this, right? Ventricular tachycardia. Ventricular fibrillation is something like this. What you just saw. Pulseless electrical activity normally is like this. Something coming, but you can't identify. Asystole is a flat line. Okay, so this is the point where you give a shock and not shock. Most important, remember, after the shock, no pulse check. This is an important point. After the shock, no pulse check. Once you give the shock, after that, no pulse check. Clear? This is an important question. Next. A 20-year-old young male patient was given brachial plexus block with 0.5% bupivacaine for open reduction internal fixation. Shortly after the injection, the patient suddenly became unresponsive and the pulse was not recordable. So which of the following would be the best course of management for this patient? Yes, it has an anesthesia question, but it is more dealing with the CPR. So you do CPR with a 20% intralipid, or you do CPR with use of soda bicarb, or you use CPR with dopamine in this patient because unresponsive and pulse is not recordable, or CPR with calcium. Yes, guys. Dr. Manik Rana, absolutely correct. Okay, absolutely correct. CPR with 20% intralipid. So you have given a brachial plexus block to the patient. We have used 0.5% bupivacaine and we were giving it for a block. Shortly after the injection, the patient has become unresponsive and the pulse is not recordable. So what am I expecting in this patient? I'm expecting local anesthesia, systemic toxicity. The local anesthesia, because I have used 0.5% bupivacaine. And remember, bupivacaine is the most cardiotoxic local anesthesia drug. It's the most cardiotoxic. You get the maximum complications with bupivacaine. You guys never see complications with lignocaine. All of you must have taken so many sutures all your life, right? Internship, post-internship, being as a resident. But you have never seen so many complications with lignocaine. But you see them with bupivacaine, right? Why? Remember the classification? Remember the classification we just saw? You will, when I discussed with you the classification, do you realize the drug bupivacaine is a part of highly potent and longer duration of action, and these drugs are also highly toxic. On the other hand, lignocaine is intermediate duration, intermediate potency, and this drug is intermediate toxicity. So you do not get lot of toxicity with lignocaine or prilocaine, but you get lot of toxicity with bupivacaine. That is the reason why these two drugs, right, lignocaine and prilocaine, because they are less toxic, they are also used for intravenous regional anesthesia or Bayer's block, last year's question. They are less toxic, but bupivacaine is highly toxic drug. Okay, so coming back to the question, so the drug is bupivacaine, hardly most cardiotoxic, and because the drug is expected to have gone into the bloodstream when you gave the block, remember the block was supposed to be given close to the nerve, but somehow the other it has gone into the bloodstream, and this has led to local anesthesia systemic toxicity where you get CNS symptoms and CVS symptoms. Normal CNS symptoms come before CVS symptoms, but in bupivacaine CVS symptoms happen at the same time of CNS. Patient becomes unresponsive, there are arrhythmias, and the treatment of local anesthesia systemic toxicity, apart from anticonvulsants, antiarrhythmics, ABC and CPR, is used of 20% intralipid. So that is the correct answer. Okay, next question. A 20-year-old male patient is undergoing strabismus surgery under GA. During the procedure, again, it's a clinical question and hence I've kept it, right? During the procedure, the patient suddenly develops a rise in temperature, a rise in carbon dioxide level, and muscle rigidity. Which of the following drugs is most likely implicated? Is it cisatracurium, saxamethonium, D-tubocurare, or rocuronium? Dr. Manik Rana says, why do we need to add adrenaline when we use 20%? Good question. Dr. Manik, shall I come that after a while? Let me finish up this. No, let me go back. I got an answer from Dr. Serene, B. Right, so first let me mark the point. Dr. Serene has given the answer and it is B, absolutely correct. It is succinylcholine or saxamethonium. Now talking about ADR. So Dr. Manik over here. So local anesthesia systemic toxicity, 20% intralipid, and Dr. Manik is right. We also give small doses of adrenaline, right? Small doses of ADR are also used. Why do we use small doses of ADR? So guys, the point is when we speak of the complications of local anesthesia toxicity, the drugs, so what can happen is arrhythmias, which are the cardiac problems. The most problematic thing in the CVS is not a decrease in heart rate and BP. The problem is going to be when it leads to arrhythmias in the patient, right? Arrhythmias and a cardiovascular collapse. Here there is convulsion. Now the point is the convulsion or the CNS symptoms are normally reversible. They can be treated. But these symptoms normally become irreversible. And therefore, the point is these arrhythmias would lead to a cardiovascular collapse. And when it leads to a cardiovascular collapse and the treatment is irreversible, in that case, the patient would be dead. So this is a very dangerous condition with bupivacaine. It's not like a high spinal or something. Here, it is very, very dangerous if it is local anesthesia systemic toxicity. So what happens is, because there may be a cardiovascular collapse and the heart stops beating, that's why you use small doses of ADR so that the heart does not stop. It prevents that serious collapse completely and the heart keeps on beating. That's the point of using adrenaline along with 20% intralipid. Is that okay? Dr. Manikarana? Clear? But good question. Apart with 20% intralipid, normally this has never been asked in the exam, but yes, it has been mentioned everywhere. Whenever you will discuss, have a discussion on the toxicity, you will always see even this point has been mentioned, but this has never been asked in the exam. Okay? Yes? Okay. Talking about this point, simple question. The point was to diagnose what is the condition, right? Here you just had to diagnose what clinical condition has been given. A patient is undergoing strabismus surgery, ophthal basically, and therefore sudden rise in temperature in the OT. Remember, in the OT, normally hypothermia takes place. Cold OT temperature, cold IV fluids. You are not expecting high rise in the temperature. Apart from that, rise in CO2 levels and muscle rigidity. These three things suggest that the patient is having malignant hyperthermia, a common, not a common condition, uncommon condition that is associated with genetic disorder of the sarcoplasmic reticulum, right? So this is basically malignant hyperthermia, which is a genetic disorder of sarcoplasmic reticulum having a ryanodine receptor gene abnormality, and this is basically a calcium release channel, right? So it's a calcium release channel. This patient is normally talking, walking like all of us, and when you give inside the OT, before that the patient is fine. But if this patient comes inside the OT, and in OT, I give the patient anesthesia drugs like volatile anesthetic agents. Volatile anesthetic agents means the maximum is seen with halothane, or if I give the patient succinylcholine or suxamethonium, or even lignocaine. This is one of the complications of lignocaine that can take place, right? And in a patient with genetic disorder, not in everyone. So here what happens, from the calcium release channel, there is increased calcium release that takes place that alters the electrolyte imbalance, which leads to arrhythmias. Then this increases the metabolism, leading to increased temperature. The temperature increase because of increased metabolism suddenly raises the temperature, right? And this does not decrease. Why? To decrease the temperature, you need to stop the calcium release. If you don't stop the calcium release, the temperature will keep on increasing, and the patient will be dead. That is why it is called malignant hyperthermia. Apart from that, there is increase in carbon dioxide production, and because muscles are involved, you get muscle rigidity, myoglobinuria. All this is there. The same points which are mentioned in the question. The only treatment of this condition, again asked in the exam, is dantrolene sodium. In the OT, this is the only treatment. Dantrolene sodium is the one that stops calcium release and treats this condition. Clear? So we are done with this part also. Important question, malignant hyperthermia. Remember, malignant hyperthermia is always an important question which you're supposed to know. Always. Next. 30-year-old patient presented with headache, vomiting, fever. Meningitis is suspected. Which is the last structure you will pierce before entering the lumbar cistern while performing a lumbar puncture? A same question regarding lumbar puncture was asked in this year's May INI-CET. All of you remember that? You've seen that paper, PYQ, right? Regarding lumbar puncture, but this is much more easy than what was asked in the exam. Okay. Lumbar puncture was asked in the May INI-CET. So here, which is the last structure we will pierce before entering the lumbar cistern? Is it arachnoid, dura, ligamentum flavum, or pia? So Dr. Pratiksha says an answer A, arachnoid. Correct. Arachnoid, right? So you get the skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum. When you come through the ligamentum flavum and you puncture ligamentum flavum, you come to the epidural space, right? So therefore your epidural space is just after the ligamentum flavum. So the last structure that you pierce while giving epidural is ligamentum flavum, right? This is the last structure pierced while giving epidural. But once epidural space goes away, the next part that you see is the dura. After the epidural, we get the dura. After the dura, we get the arachnoid. And after the arachnoid, the space after the arachnoid is basically called as the subarachnoid space. This subarachnoid space is what contains CSF, right? And spinal anesthesia is given over here. So when we speak of spinal anesthesia, we puncture all these layers and we come over here. So the last layer punctured while giving spinal, because spinal anesthesia is given over here in the CSF. All of you are aware of that. This is where we give spinal anesthesia. So spinal anesthesia is in subarachnoid space inside the CSF. So the last layer punctured in spinal anesthesia is arachnoid. Okay. Another important question that comes in the exam, that is, you have seen this is as a subarachnoid space. Where is the subdural space? So subdural space, remember, the space in between this dura and arachnoid, this small space in between the dura and arachnoid, this is what is called as a subdural space. Okay, subdural. Thumbs up, everyone. Okay, subdural. Clear? So these are all the layers which are important, right? Clinical question again, clinically or anat question. Okay, so this is also done. Another question. A child with a road traffic accident is brought to the casualty. Immediately, a blue colored cannula was taken and to this patient to give fluids and medicines. What is the gauge of this cannula? Yes, simple question, but this is where we get confused in the exams. A child with a nice, Dr. Pratiksha, good. Okay, immediate I got an answer from Dr. Pratiksha. 22 gauge, correct. Okay, 22 gauge is the correct answer. A child having a blue cannula is 22. I'll take another question like this and I'll just discuss the colors with you because colors are important. They are asked in the exam. So this was one of them. The next one. A patient has got a gunshot injury with hypotension. The rapid infusion of saline is required. Which IV cannula would be most preferred? Pink, blue, yellow, gray? So do you see what questions from anesthesia, all varied questions from anesthesia, the way it comes as clinical, right? Otherwise, we keep on studying, inhalationals. But of course, when we are teaching, this also is a part of it. But normally we are so engrossed with teaching inhalationals and IV that we forget that anesthesia has so many other questions apart from that which are so clinical. And we don't realize it. Okay. So I got one answer. Two answers. Yes. So it's A is not the answer. Pink is the most common used cannula, but here the point is you are supposed to be giving a rapid infusion, which means I need to be giving it for resuscitation of the patient. When I'm using for a fluid resuscitation or blood, I need to use a cannula with the biggest gauge, the wide bore, and the wide bore option given to us here is the gray, because gray is what gauge? It is the 16 gauge. Pink. So if you speak of the colors, right, the answer is D. Dr. Pratiksha, Dr. Shreya, Dr. Manik, correct. Okay. When you speak of the IV cannula, guys, remember IV cannulas, the most common that we use, let's go like this, the most common that we use is the pink one. The 20 gauge cannula, this is the pink one, the most common used, and this is normally used in adults, right? When we go lower than this, it becomes much more thin. So now I'm talking of the thin ones. These are the thin bore. Thin bore means they become much more thinner. So the 22 gauge, the 24 gauge and the 26 gauge IV cannula are much more thinner, right? So 22 gauge is blue, 24 is yellow and 26 is purple, which means the purple is the thinnest out of them. Where will you use it? So purple is going to be used in neonates or preterm neonates. 24 is normally used in children, pediatric patients or neonates, right? The blue one is used in children, right? Because children come right from 1 year to 14 years, right? So children, different ages, you can use the blue one. And it is also used in adults many a times. When you don't get a 20 gauge cannula for adult, I can use 22 for adult also. Now, on the other hand, you are going to find 18 gauge, 16 gauge and 14 gauge. So these ones are normally not thin bore now. These are thick bore or wide bore. They are much more thicker, right? So 18 is basically green in color, 16 is gray in color and 14 is orange in color. Abroad, you get another one which is 17, right? A 17 gauge is also available, which is white in color. Normally, we have not seen that in India. All right. And these are the ones that are used for blood or fluid resuscitation in case of emergency. Blood or fluid resuscitation. And if you don't get an IV cannula, guys, remember the next option is to try intraosseous cannula. Intraosseous cannula means it's in the bone. Intraosseous cannula means in the bone. The most common bone that you have is the tibia, right? The tibia can be proximal or distal. Apart from that, it can be put in the femur, anterior superior iliac spine, sternum, right? And even the humerus. But the most common use is tibia for intraosseous cannula. And remember, intraosseous can be used in adults also apart from pediatrics. And it is used only in emergency when there is no IV cannula. For example, a burns patient, if you have to give the whole, all of you know how important is Parkland's formula to calculate the fluids for a burn patient. Every year the question comes from burns. But if you don't have an IV cannula, what's the use of Parkland formula? So therefore, if not an IV cannula, the next step is to take an intraosseous cannula. Right, so it is always used in emergency for an emergency vascular access. When you don't get an IV cannula, we prefer to use intraosseous for a vascular access. Dr. Pratiksha says flow rates. Okay, I'll tell you the flow rates as well. Flow rates with na padna nahi chahiye, not very important, but still there's no harm in knowing the flow rates. I'll write it here only. So remember guys, the pink one has a flow rate. So we are discussing about the flow rate in ml per minute. Right? How much is each of the IV cannula going to give in ml per minute? So remember, in the center, anywhere around 50. So around 54 to 55 ml per minute is for the pink one. So if it's going for a child, it's going to be less than that. So around 23 to 25 is for a 24 gauge cannula, almost half of that. In between is 33. So around 33 ml per minute is with a blue gauge cannula. And the smallest one for a neonate or a preterm neonate is around 13 to 15 ml per minute. This is the small one. But when it comes to 18, 16 and 14, they will be much more than 54. So anywhere between 90 to 100. So they say anywhere between 80 to 90, close to 100 is the green one. Anywhere between 170 to 180 is around the gray one. And around 180 and around 270 to 280 is with the orange one. I'm not saying the exact number is normally for the pink one 54, but all of the others, every company has a different number. There may be a change of 10 here and there. For example, in some books, this may be have given as 170. In some books, this may be given as 250, but this is close to whatever is there. Okay. Orange is 240. That's what I'm saying. It's a range. That's what I said. Dr. Allied and Healthcare Solution AIR 7. Okay. That's what I said. That's a range normally. But I'm just saying close to these numbers is what you need to remember. You can't remember exact numbers. As you can see, close to 50, close to 30, close to 25, close to 15. Right? You can remember something like that. After that, you can remember close to 80, close to 180, close to 270, 260. So that's how you can remember these flow rates. Okay. Right, absolutely correct. That's what I'm saying. Clear? So it's always the range which is there, which you need to remember, and that is how it is. Correct? Next question. Adjoining image indicates which maneuver? Okay, the adjoining image indicate, I think all of you already know it. Why should I waste the time? Okay, let's see the next one. Is it head extension? No. Is it jaw thrust? No. You can see in the image what is being done. The head is tilted and the chin is lifted. So this is head tilt, chin lift. Easy thing, right? This is what is done when you're doing a CPR. Remember, in CPR, a common question comes regarding the chest compression, airway and breathing. How is it you're supposed to be giving this to the patient, right? What are the parameters for this? So remember, when you give the chest compression, it is always given at the lower 1/3 of the sternum. All right, lower 1/3 of the sternum. After that, Dr. Pratiksha, Dr. Manik, all of you are correct. Huh? Dr. Allied and Healthcare Solution, all of you are correct. All of you, absolutely correct. I'm just saying chest compression, lower 1/3 of the sternum. Next point, it is 100 to 120 per minute. The third point is that it is between 5 to 6 centimeter, or basically start with inches, 2 to 2.4 inches, and 5 to 6 centimeter is the depth. But if it comes to a pediatric patient, even adult, it is 1/3 the depth of the chest, right? And after that, allow a complete chest recoil. These are the points for a chest compression, right? Always minimize interruptions. That is also another point given. Airway. Airway means you need to remove the obstruction from there, and therefore the best method to make the airway patent is basically a head, which we just saw. Head tilt and chin lift. Head tilt and chin lift is the maneuver that is normally done, and this is avoided in fractured cervical spine. So in fractured cervical spine, what we do is we lift the jaw, which is called as jaw thrust, right? Also here they say that airway, just if you find a vomitus, try to remove it out. If there's a foreign body, try to remove it out. So, okay. So foreign body, which means if a patient is choking, remember this point. If a patient is choking, is unresponsive, then you are continuing the CPR, and this is where you remove the foreign body. Okay, clear? That's the point. Breathing. Breathing, when you're giving breath to a patient. When you give breath to a patient, always remember we give 2 breaths at one time. That's why it comes as 30:2. Everywhere we give 2 breaths at one time in the basic life support. I'm not talking of advanced life support. Always give 2 breaths at one time, right? Whenever giving, 2 breaths are given at one time together. And that is why everywhere it becomes 30:2, except for a pediatric patient where it becomes 15:2 in presence of 2 rescuers. Everywhere we get 30 chest compression, 2 breath, 30 chest compression, 2 breath. But pediatric patient, if there's a pediatric patient with 2 rescuers, pediatric patient with 2 rescuers, here it becomes 15:2. You give inspiration over 1 second, look for chest rise, right? And expiration for 1 second, no excessive ventilation. No excessive ventilation. This is also important. Clear? No excessive ventilation. And then again, how do you do it? You're supposed to be doing cycles of 30:2. That's what we've seen even before. We are supposed to be doing these cycles of 30:2 continuously. For how many minutes? Everything goes on for how much time? It's about 30 to 40 minutes. There was a development of high airway pressure, increased resistance, and sudden desaturation while trying to secure a central venous catheter. What is the most probable diagnosis? Yes, guys? Okay. There was a development of a high airway pressure, increased resistance, and sudden desaturation while trying to secure a central venous catheter. What is the most probable diagnosis? Arterial puncture, pneumothorax, collapsed lung, or air embolism? Yes, guys. Right. Dr. Allied and Healthcare Solution. अरे तुम्हारा नाम भी तो होगा. It's how difficult to pronounce it is for me from here. Dr. Allied and Healthcare Solution AIR7. I know, good. Your rank. You should write AIR1, na? Why AIR7? Keep it as 1. Aim for 1. Alright? Correct. All of you given the correct answer. Pneumothorax. Okay. Development of a high airway pressure, increased resistance, and sudden desaturation while trying to secure a central venous catheter. याद आया previous question? High airway pressure. याद है? Peak airway pressure we just discussed. Remember peak airway pressure we had discussed over here that a pneumothorax hoga to peak airway pressure will increase. Do you remember this point? In a high airway pressure means airway resistance is increasing and the peak airway pressure is increased. The same point over there when you get pneumothorax, that has increased. Clear? Getting the clinical correlations now? Yes, proper clinical questions are there, hai na? Nice. Otherwise you must be thinking anesthesia mein kya clinical question aayega? See so many of them. Yeah, Dr. Basit. See, such a wonderful name you have, Dr. Basit. What a wonderful name. Why didn't you keep your name like that? Look at Dr. Basit. Such a nice name he has, and he's put his name as Allied, Dr. Allied and Healthcare Solution AIR7. Dr. Basit, keep a name, so that we can tell you and call you Dr. Basit. It's so nice to call you like that. Okay? So it's so easy to call you this way. Right? Such a lovely name. Okay? Now, coming back to what we were discussing. Development of high airway pressure, increased resistance, and sudden desaturation while central venous catheter. All of you know the answer, pneumothorax. But next point is, which is the most common complication seen with a central venous catheter? Agar ye question aa gaya, which is the most common complication that you see? Remember, the most common most welcome, Dr. Basit. Okay, arterial puncture. Remember, arterial puncture, guys, is the most common complication that you see, right? Agar koi ye puchega, because central venous catheter is put in a vein और vein के side में you get the artery. So normally arterial puncture immediately हो सकता है, which leads to hematoma. So that is the most common, right? Yes, arterial puncture. That's what I was saying. Also remember one more point here, that another question has been asked in INI-CET, that what is a specific complication, especially of a left-sided central line, right? So remember, especially when you're putting on a left side central line, especially subclavian, you know the thoracic duct is going from there. So you get a specific complication seen on the left side, which is chylothorax. And this question has been asked in the exam. So if they ask you a specific complication seen on the left side, specific. So two complications which are very commonly seen are arterial puncture and pneumothorax. Out of that also, I will go for arterial puncture as the most common. And a specific complication, especially seen on the left hand side, is chylothorax. Remember this because thoracic duct goes on the left side. So if you insert a left-sided subclavian or internal jugular, it's going to, especially with subclavian, it can cause chylothorax. Clear? So these are the complications of central venous catheter. Important question. Also remember, normal CVP is around 8 to 10 centimeter of water. So it tells you the fluid status, and some books have mentioned as between 5 to 8 also. But I feel 8 to 10 normally has been given. Sir, isn't air embolism? देखो एक और change is good. Doctor change is good. अरे आपका भी तो अच्छा नाम होगा. Doctor change is good. Dr. Mani Karana says hematoma, and Dr. change is good. Isn't air embolism also associated? Yes, air embolism also can take place. Remember, it's double thing. A central venous catheter can be used for removal of the air embolism also. It can be used for removal of air embolism also. I'm not denying that, right? Air embolus, you can use this to remove it as well. But at the same time, if you open it to air embolism becomes a complication. So remember, both the things are there for a central venous catheter. Yes, air embolism is also associated. I'm not denying that, but this is rare. It's not very common. Air embolism with central venous catheter will happen if you have opened the vein to the air directly for long and the air gets sucked inside or gets pulled inside. This is where air embolism takes place. Plus also the amount of air that needs to go in is much high in volume. It's not about one bubble or two bubbles of air. That is what is going to cause air embolism. But yes, air embolism is also one of the complications. That is correct. So arterial puncture is a complication. Yes, pneumothorax also, air embolism also. These are all common. But from here, what they have said, the answer is pneumothorax. The most common is arterial, and left-sided specific is chylothorax. Okay. Next question. Spinal cord in adult terminates at what level of vertebra? Anatomy question, anesthesia question related to the spinal cord. Okay. So when we are giving the spinal, I'll just take about 2 minutes more. Huh? Almost done. I'm done with all the questions. One more question I have, and after that I think we'll be done. Yes. So spinal cord in adult terminates at what level of vertebra? This has been asked in the exam. Dr. Pratiksha says C, lower end of L1. Correct. Okay. So when you speak of an adult, the spinal cord starts from middle oblongata and finishes over the lower border of L1 or upper border of L2. And that is why when we give spinal anesthesia, we give at the L3, L4 level. When you give spinal anesthesia, the most common is L3, L4, or you can give it L4, L5. But remember, the most common is L3, L4. This is most common. Also, how do you identify L3, L4 interspace? That's also a question. The line joining the highest point of iliac crest. Remember, Tuffier's line. It's the line joining the highest point of iliac crest. Line joining the highest point of iliac crest. You know, anesthesia guys, you must have seen at the back, they try to palpate something before giving spinal. So we are trying to find the Tuffier's line, and from the Tuffier's line, right, the line joining the highest point of iliac crest. Okay, so this is your Tuffier's line, which corresponds to L3, L4 interspace, and that's how we give the spinal anesthesia. Also, another point, lower end of L3, around L3 is where you are going to get for in a child. In a child, it finishes off L3, right? Tuffier's line between. हाँ, उसमें एक doubt है यार, Dr. Basit. Normally what happens, Dr. Basit, is that, you know, when they say Tuffier's line, again, you're right. Many times the books, that's a confusion. So what books has said that Tuffier's line corresponds to L4 interspace. You know, the books also are very smart. they have mentioned this word that Tafier's line corresponds to L4 interspace. What is L4 interspace? L4 interspace can be L3, L4, and it can be L4, L5 also. So that is why this dilemma comes that, what is the answer exactly? So you don't know exactly what they'll say. In every person, it might be different, but most of the books then say L3, L4 it corresponds. And of course, some books have said L4, L5. But what is written many places is that Tafier's line corresponds to the L4 interspace. Oh, no, that can be L3, L4 or L4, L5 both. And that is why this question comes. I mean, this dilemma comes. And I was saying lower border of L3. This is where that gets over in a child, the spinal cord. Clear everyone? So we discussed with this anatomy also. ठीक है, ये भी हो गया. Hopefully doubts are cleared. Right? Last question, as I was saying, according to me, the last one only. This is the last one I had set. A COPD patient in the ICU was on oxygen therapy, right? With mask, on mask with 2 liters of oxygen. Wait, एक typing error हो गया. Sorry, a patient with mask नहीं was on oxygen therapy. हाँ, ठीक है, correct, ठीक. I thought it was typing error. A COPD patient in ICU was on oxygen therapy with mask at लिखना चाहिए था, sorry. और with भी चलेगा, with 2 liters of oxygen. He was found to be hypoventilating. PCO2 on the blood gas analysis was 64. What is the best strategy for this patient? Increase the FiO2, decrease the FiO2, start BiPAP, intubate, and start on ventilator. All of you know such questions come in the exam. Again, clinical. This will be the last one. Okay. Yes, guys. Acha, Dr. Change is good also mentioned the name, top field. Nice, such a lovely names you guys have here. तुम लोगों ने कैसे कैसे नाम रखे हुए हैं, इतने अच्छे नाम है तुम्हारे. अच्छा, तुमने टफियर्स को ऐसे लिखा था 2 पे, आई थॉट इट्स अ नेम. ओके. अच्छा, मे बी सी और मे बी डी. और डॉक्टर प्रतीक्षा से सी, डॉक्टर मानी कराना से मे बी सी, और डॉक्टर चेंज इज गुड से सी और डी. ठीक है, आंसर इज सी, स्टार्ट बाईपैप. ठीक है. पेशेंट इज ऑन ऑक्सीजन थेरेपी एट 2 लीटर्स. ठीक है, 2 लीटर्स है. ओके. पेशेंट इज फाउंड टू बी हाइपोवेंटिलेटिंग. हाइपोवेंटिलेटिंग का मतलब है पेशेंट का जो रेस्पिरेटरी रेट है, ओके, हाइपोवेंटिलेटिंग, दैट हैज गॉन डाउन. पेशेंट का रेस्पिरेटरी रेट हैज गॉन डाउन. You are talking of a COPD patient. That's the first thing. Okay. We are talking about a COPD. Let's take it one by one. We are talking of a COPD patient who is at 2 liters of oxygen, right? At 2 liters of oxygen, his respiratory rate has decreased. Because his respiratory rate has decreased, his carbon dioxide has increased, right? This is what is given in the EBG, right? CO2 has become 64. Now, if the respiratory rate has decreased and CO2 has increased, and if you increase the FiO2, if I increase the FiO2, his respiratory rate will decrease further and CO2 will increase further. So this is out of question. You cannot do it. Decreasing the FiO2 is further going to decrease the oxygen of the patient and increase the CO2. Again, this is not possible. So you guys are right. Answer would be C or D. But remember, when you give BiPAP, this is a non-invasive ventilation. Means you are giving it through a face mask. When you are intubating, this is called as a invasive ventilation. So always before you give a invasive ventilation, invasive means putting a patient on ventilator, it's always better initially to give a trive or a non-invasive ventilation, the same thing which was given during COVID, right? So when you speak of oxygen delivery devices, remember the nasal prongs is the one which gives lowest oxygen. Then you come to the simple face mask. Then you come to a partial rebreathing mask, which gives around 70%. Then you give to a non-rebreathing mask, which gives 90%. You come to high flow nasal cannula, which gives around 100%. Then the next step is a non-invasive ventilation. And in non-invasive ventilation, we are using a tight face mask through us and giving CPAP or BiPAP. Remember, CPAP or BiPAP, the first point is that patient has to be awake, spontaneously breathing. And that is why CPAP, BiPAP is contraindicated in an unconscious patient. Sorry. Contraindications to CPAP and BiPAP are an unconscious patient, a sedated patient, a fracture of the face patient, right? That is non-invasive. And then in case the patient is not improving with non-invasive, is not improving. Of course, the next step for me is to put on invasive ventilation, where I'm going to put the patient on ventilator. The point is CPAP and BiPAP is given from a face mask, because of which the patient has to be spontaneously breathing. but invasive ventilation is given from a ventilator. And in that case, I'm taking complete hold of the respiratory efforts of the patient. I'm controlling the respiration of the patient through the machine. And here we have to put an endotracheal tube or tracheostomy. Because you're putting endotracheal tube, that's the reason why it becomes invasive. And before doing invasive, it's always better to give a try for non-invasive. So therefore, the next step for this patient was start BiPAP. Is it clear, everyone? Okay. So we finished off all the questions, and you must have realized no question about ketamine, no question. I hope no other question. Or कोई question set तो नहीं किया? No, I haven't. So this was my number of questions that we discussed as one, from the various clinical aspects of anesthesia, right? My Instagram ID is dr.vinish. You can follow me and ask me questions directly over there. I'll share my Telegram ID also with you. You can ask me questions directly, and I'll be happy to help you out with something from whatever I know about. Okay, my Telegram ID, that is Dr. Vinish without the dot, and Instagram ID is dr.vinish, right? That is for Instagram. So you can connect with me on Instagram also and ask me questions directly there, or you can connect with me on Telegram and ask me. It's not a group, it's a direct thing where you can tell me. Sir, preparing for NEET PG 2025, if you could give, Doctor Change is good, if you could give the names of topics which you didn't cover yesterday and we should do it for NEET PG. Acha, yesterday matlab you're saying FMGE wala? Okay. Wait, एक-एक करके बोलने दो. If you could give names of topics which you didn't cover yesterday and we should do for NEET PG. Okay, so let me think of topics that I didn't do yesterday. Yesterday कल मतलब मैंने कौन कौन सा टॉपिक नहीं किया था, मेरे को याद भी नहीं आ रहा है. Wait, let me think. Okay, you have to study. Remember those drugs, pre-medication drugs. I did not cover that yesterday. Let me think about it. Let me think about it. I did not cover what things I didn't cover yesterday. Pre-medication drugs I did not cover. What other thing was not there? I think all this oxygen and all I covered. CPR I covered. Most of the things I had covered here. Spinal blocks I did not cover. Right? Blocks I had just covered intravenous regional anesthesia. Apart from that, I did not cover anything else. And spinal epidural. Wait, let me think. Difficult airway. Difficult airway predictors I did not cover except for Malam Patti. There are other predictors of difficult airway also. Yeah, actually I tried to cover everything. मेरे को याद नहीं आ रहा मैं और क्या हिस्ट्री ऑफ एनेस्थीसिया नहीं कवर किया था, बड़ा इंपॉर्टेंट नहीं है. What else? Otherwise I think apart from that I covered everything. Inhalationals, IV, properties of individual drugs, I covered that also. What drugs are used where, muscle relaxants I covered. Opioids study, right? Opioids I discussed I think with you alpha-2 agonist also, वो भी डिस्कस कर लिया था. और कौन सा टॉपिक नहीं डिस्कस? I think I discussed most of the things with you here. Although I tried doing PYQ, was able to get most of them, sir, but if some topics are left to do, tell. I don't think so, yeah. Most of them I've covered. Dr. Manik, thank you so much. Dr. Manik Rana says good. Thank you, Dr. Manik Rana. Dr. Pratiksha is asking me, how is anesthesia branch? Is it hectic? No, it's good branch. Hectic hoga, but you have people to help you. I have a, you see my YouTube video with, I've got a YouTube podcast. Search for my name and look for a podcast that I've done with Dr. Bhatia. Okay, you can see with that. You can check out that where I've discussed all about anesthesia. You can see that podcast, and that it will clear all your doubts. This branch is not hectic. It depends as to what you count as hectic. It depends as if you want to have time for yourself or not. And more than anything else, I will always tell you, if you pick up anesthesia, remember one point. It is not you who will not be happy. It is your relatives and your parents who will not be happy. Because they will feel, ki, what am I doing? They are never happy. They think कि डॉक्टर बन के क्या किया. And let me tell you, I am a qualified chest physician before I have done anesthesia. So I have heard more than anyone can hear. Because I am already a qualified chest physician, I still choose to practice anesthesia. Okay, I did further things in anesthesia, but I have a degree with chest medicine also, respiratory medicine. But people around you are not happy. The patient's relatives, they think you are not a doctor. I mean, in the sense that patient relatives, the importance that you get from your family and the importance that you get from patient's relatives, this is missing. In case you are a surgeon, in case you are a pediatrician, in case you have done medicine, In case you've done orthopedics, whenever the patients are coming to show you, their relatives are coming to show you. So therefore, what happens is their relatives are also there. So if you have seen a patient in being a physician and you cured the patient well and the patient feels good, he will refer you to 2 or 3 other people, right? That this doctor was good and kindly show him. If you give anesthesia to someone, no one will come and tell you क्या anesthesia दिया है यार, एक और बार जाके बेहोश होते. Understood? You don't get the follow up. All these branches basically have a follow up of patients where the patients become your own, whether you're in government or private. They will follow you, they will refer more patients, they will tell you ki, even in a government sector, forget private, why to speak about private? You find one surgeon in the hospital to be very good, people will ask in the government sector also, how is this surgeon? Okay, how is this surgeon? Let's go to him for surgery. But no one will say, how is that anesthetist? I will go only to that anesthetist for anesthesia, right? The point is you are working as a director of a movie, you are not working as the actor. But always remember, if an actor is also important, similarly the director of the movie is also important. A movie cannot be made without a director. It's not an actor who makes a movie always, the director runs the show. The point is anesthesia guys are normally like a director or a part of hospital. So you are one of the most important persons in the hospital. You will not call a surgeon for doing a CPR. You will not call a surgeon for giving IV cannula. You will not call a medicine person for putting a Ryle's tube that no one can do. All of you must have worked in a hospital. You have worked in emergency. You have worked in casualty. If someone is unable to intubate a patient, the first thing you do is called anesthesia or the ICU person. You can't insert IV line. The first thing called anesthesia or ICU person. You can't put a Ryle's tube. You call the anesthesia or ICU person. If you don't understand anything in hospital, the first thing you do is call the anesthesia person. You must have seen that. So remember, when you pick up this branch, the negative aspect of anesthesia is that you don't get validation from the patient's relatives or the patients directly. The lack of validation, if someone wants validation, oh, what a doctor you are there. So this lack of validation is the biggest problem. If it does not affect you, you will be very, very happy in the field. But if you want to be validated by the patient, you want to be validated by the relatives, you want to be validated by your relatives, in that it is not the branch. It depends as to what you are thinking. Is it okay, everyone? Right? Thank you so much. It was a very nice session. Thank you so much. Thank you so much. Okay. Right. Hopefully this point is clear. Dr. Pratiksha. It's a good branch, huh? Trust me. For me, it's been so many years right now. So many years. Remember, for me, anesthesia mein, right? How many years has been in anesthesia now? After clearing my anesthesia, मेरे को 20 साल के ऊपर हो गए. ठीक है? It's more than 20 years after finishing off anesthesia. Okay. So the point is not about being hectic or not. It's about whether the kind of thing that you're looking out for. Any other questions, guys? I think I've tried to clear all the doubts. If there's anything else, you can ask me. Dr. Manik says guitar. यार YouTube पे शायद गिटार की आवाज नहीं आती यार. Let me see. I've kept a guitar. लेकिन गिटार दूर रखा है. YouTube पे कैसे करेंगे गिटार? It doesn't catch up. Actually, no, the settings of the OBS are such that guitar doesn't come. I'm not very sure whether you can hear it. Let me try. Just give me a second. सर एक लाइफ लेसन भी दे दो साथ में कि इम्पोर्टेंस की इज इट इम्पोर्टेंट. एक सेकेंड डॉक्टर सर एक बार रैपिड सीक्वेंस इंट्यूबेशन. ठीक है, आई विल डू दैट रैपिड सीक्वेंस इंट्यूबेशन. एंड डॉक्टर चेंजेस गुड इज सेइंग सर एक लाइव लेसन भी दे दो साथ में कि इंपॉर्टेंस रियली इंपॉर्टेंट. अरे ये मेरे को नहीं समझ में आया क्वेश्चन. आई लाइक एनाटॉमी बट द सेम थिंग कि लोग क्या बोलेंगे. ओके हाँ सी राइट आई अंडरस्टूड योर पॉइंट. हाउ अबाउट एनाटॉमी. ओके सो यार एनाटॉमी इज वेरी गुड. आई नो फ्यू पीपल हु आर डूइंग एक्सीलेंट इन एनाटॉमी, राइट. एंड लेट मी टॉक अबाउट PW itself. Dr. Pradeep Pawar, you must be knowing. He's a close friend of mine since childhood. I'd rather say that, right? You look at him, look at that. When you speak to him also, the way he speaks about anatomy. If you speak to Dr. Pradeep Pawar, or whenever you have a session, you can talk to him also directly. You will see that how proudly he feels about anatomy, with how much passion does he teach anatomy. So when you see that, you'll realize it. And not only him, but you take any of the platforms. And let me tell you, any of the platforms that you take, look at all the anatomy teachers at any platform. I'm not naming them. Let's forget about any platform that you take. Everyone is so passionate about teaching it. Have you seen the way they are drawing it? Have you seen how they explain each and small point? they take passion out of it. So guys, if you are good in your branch, things won't stop you. Yes, as you said, relatives, home, and patients. Three things are missing. But in spite of that, remember, if you're so fond of clinical practice that you want to continue and you want to teach anatomy also, always remember after MBBS, you can do MS. That anatomy is always considered anatomy MS hota hai, right? You kar liya. But who is stopping you to practice as a practitioner in the evening? You can have your own OPD in the evening, right? In a place like Mumbai and all, where corporate hospitals are also, they're not denying, but a lot of people have their own OPD in the area that they're staying or the house they're staying. So evening, the whole day you can keep on teaching in the medical college, right? You can be the professor in the medical college, and we need good people there, right? Older people will retire, new people will be needed, and in the evening you get time, you can do OPD unless and until the college not allows practice. Otherwise, you can have your normal OPD that you can do it, right? So this can always be done, but I will always say pick up a branch that you choose or that you like. For me, let me tell you, I had picked up chest medicine, I did respiratory medicine, but my problem was the OPD patients. I stopped liking the OPD patients. And the reason is that because I was not getting the satisfaction of treating, in the sense that when an OPD patient used to come for respiratory, and I have done from a government hospital in Bombay, right? The hospital used to have, you must have heard of Sion Hospital, Lokmanya Tilak Municipal Medical College. It's next to Dharavi. It is full of patients, right? You never knew which patient has come, which patient has gone, and what patient, if your medicine has cleared someone or not, has made someone well or not. I could not get the immediate satisfaction. In the same respiratory medicine, I had an ICU. In that ICU, I used to love working every patient, and even if that one patient was saved, it was a wonderful experience for me. And this is what made me pick up anesthesia later on. And with that, that one patient I'm looking and I can see what's happening to that one patient, whether it is the OT or it is the ICU, I was concentrating only upon that, and this patient gets okay. OPD, you get multiple patients, one after the other. You'll be seeing 20, 30, 40, 50, 60 patients. Not very easy to handle. For me, this was not the branch. That is what I realized later on. So you need to pick up based on that. Last point, Dr. Pratiksha has asked me to explain something about rapid sequence induction. So remember, rapid sequence induction is basically done in a full stomach patient. Okay, when a full stomach patient, जिसमें bag mask ventilation is contraindicated and is coming for emergency surgery, right? So if you have intestinal obstruction where you can't wait, immediately patient has to be operated. What do? The first step is that you need to pre-oxygenate the patient, which means fill up the lungs with oxygen. So you pre-oxygenate with 100% oxygen for 3 to 5 minutes. What this does, guys, is this causes denitrogenation. Denitrogenation means whatever nitrogen is there in the air gets replaced by oxygen. So the lungs become completely full with oxygen. The advantage of giving pre-oxygenation is that it decreases the chances of desaturation, of a saturation falling down during the procedure of intubation. Because this patient has come for emergency surgery, remember, whenever we give anesthesia, the first step is that we give IV drugs to the patient. After giving IV drugs, then we start the anesthesia medications where we give propofol and then we give muscle relaxant. This propofol works, I'm talking of general case. Propofol starts to work between 10 to 15 seconds, right? Starts to work, and muscle relaxant will have its effect normally is going to take place between 3 to 4 minutes. Like vecuronium or atracurium, all of them are intermediate acting. The onset of action for all of them is 3 to 4 minutes. So what are you going to do for these 3 to 4 minutes? So for these 3 to 4 minutes, we hold the bag mask and we do a bag mask ventilation. You must have seen all the anesthesia people holding the mask on the patient's face. And after that, once 4 minutes are done, the muscles are paralyzed. After these 4 minutes is when we intubate the patient. So the point is, when you're giving anesthesia, when you've injected the drug and when you intubate, there is a time of 3 to 4 minutes where you're doing bag mask ventilation. But if the patient is full stomach, the biggest problem is I can't do bag mask ventilation, because if I do bag mask ventilation, I'm increasing the chances of aspiration further. That is the reason why bag mask ventilation is contraindicated. So therefore, in this patient, I want to do things as early as I can. I'm coming to that point. So therefore, the point is, now you pre-oxygenated the patient and here you have not done anything else. What I did was, I told the patient to breathe spontaneously for 3 to 5 minutes. But many times in emergency, you don't have the time. So you tell the patient to take 8 vital capacity breaths. 8 vital capacity breaths means deep breaths. So if this is your spirometry graph, all of you know what is vital capacity, right? This is tidal volume, inspiratory reserve volume, expiratory reserve volume, and what is left is basically residual volume. So your vital capacity is this part. So this is what is called as a deep breath, right? So this is what you're doing. You ask the patient to take 8 deep breaths. This fills up the lungs with oxygen and decreases the chances of desaturation for what you're going to do next. After this, the next step is to protect the airway by giving Sellick's maneuver, which I just discussed with you. Sellick's maneuver or cricoid pressure of 30 Newton. So what you've done is you pressed upon the cricoid cartilage and this shuts off the esophagus. Because it shuts off the esophagus, this has decreased the chances of aspiration. Another important point is cricoid pressure is given by assistant, not by the person holding the mask. Cricoid pressure is always given by assistant, right? So this decreases the chances of aspiration. So let me show you the diagram here also. So if this is the trachea, right? If this is the trachea, this was the cricoid, these are the tracheal rings. So what you do is when you press the cricoid, it shuts off the esophagus like this. So if this is the esophagus, by chance there is regurgitation happening, that cricoid is the only complete ring and this basically shuts off the esophagus. So this is given by an assistant. And now what you're going to do is when the assistant has given cricoid pressure, I will give the induction agent of choice. Normally it is ketamine, but people use propofol and thiopentone also. Immediate, you will give a muscle relaxant. You want the fastest acting succinylcholine or rocuronium. Why you want fastest acting? Because all other drugs are 3 to 4 minutes. So I want to use the fastest acting muscle relaxant, which is succinylcholine or rocuronium. So succinylcholine is basically working within 30 to 60 seconds and rocuronium works between 60 to 90 seconds because all others are working between 3 to 4 minutes. So remember, for this 60 to 90 seconds and for 30 to 60 seconds, I cannot do bag mask ventilation. That is the reason why I needed to fill the lungs with oxygen. Normally for 3 to 4 minutes, I was doing bag mask ventilation. But here 60 to 90 seconds, no bag mask ventilation, no positive pressure ventilation, nothing is to be done for 60 seconds. And that is why the patient might desaturate. And that is the reason why we need to fill up the lungs with oxygen, because for the next 60 to 90 seconds, maybe I cannot do IPPV. I will not be giving bag mask ventilation. That is why I want to avoid desaturation. Thumbs up, guys. You understood this? Did everyone understand? Okay. And now what has happened is once you have given muscle relaxant, induction drug, you waited for 30 to 60 seconds. This would take about 60 seconds for the complete action. After this is when you intubate the patient. So remember, intubation is done. You intubate the patient. So once you give the induction agent, you gave the muscle relaxant, 30 to 60 seconds for succinylcholine or 60 to 90 seconds for rocuronium. After that, you intubate the patient. Beach mein there was no bag mask ventilation in this time. Intubate the patient with the cricoid pressure, which means the cricoid pressure is still there by the assistant. You intubate the patient, you inflate the cuff, you confirm the position. You confirm the position with what? The best method is what? ETCO2, I mean direct visualization. All those methods are there, right? All of you know how to confirm, asked in the exam. After confirmation, this is when you remove cricoid pressure. This is how you prevented the aspiration. This is where you remove the cricoid pressure. Clear? Okay, thumbs up. I already got thumbs up from Dr. Change is good and Dr. Pratiksha. Hopefully this point is clear. Okay, so this was rapid sequence. This is what is called as rapid sequence induction or rapid sequence intubation. Okay, guys. Okay. Hopefully doubts are clear. And I'll be coming with a NEET PG marathon also. ठीक है, हम लोग का शायद एक नीट पीजी मैराथन भी होगा. आई थिंक यू मस्ट हैव गॉट द डिटेल्स गाइस. यू मस्ट हैव हैड इट आल्सो. वी विल बी डिस्कसिंग दैट आल्सो. इफ यू वांट मी टू कवर अ स्पेसिफिक टॉपिक, लेट मी नो. You can put it on the Instagram, you can put it on Telegram, you can share with me the topic if you want. I'll cover that with a special part there. Okay, I'll try to focus on that part when I'm taking a NEET PG marathon. Is that okay, guys? My session probably would be on 17th. Okay, I think we are starting on the 15th or 16th. Some of the topics are already done, and I think mine is going to be on 17th. I'm not very sure. We'll have to check. Mostly 17th. That's going to be a NEET PG marathon. Okay. All right. Okay, guys. So any questions, any doubts, you can connect to me on Instagram. Okay, connect to me on Instagram and ask me any questions or doubts. I'll try to solve them to the best of my knowledge. Okay, and all the best, guys. Do well, and we feel very good when you guys clear, secure your rank. It makes us feel as if we have cleared, right? At this stage, it makes us feel that. Okay, so all the best. Do well, and thank you for joining me. It was a wonderful interactive session, and I loved it. Thank you so much. Take care and all the best.